practical pediatric endocrinology course is actually something which has been quite close to Growth Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time. If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedEClasses, which is a learning platform, and this is really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with the number of videos which are now available on the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growthsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows, providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they're all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. I'm in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser time. So we've got Dr. Mahesh Maheshwari, Dr. Anurag Katia, Dr. Bansal, who has already been introduced. And we've got Dr. Riddhi Patel, who is one of our fellows from Regency CDR, one of the most hardworking and the most accomplished person, and who has done a lot of work in pediatric endocrinology. And it is often difficult to do original work. She actually created from scratch a bone age application, and she'll be talking about that. I will also be joined by my student, Dr. Sayan, who will be moderating the session. Before we start with the cases, just a basic aspect which we have to just look at regards to growth failure. So growth failure, as discussed, is a common problem. 2.5% of all children have growth failure. 80% of them are physiological. 20% have a disorder. And that's where the catch is. Which children are physiological, do not require evaluation, which children have a disorder, and that's what we're going to do over the next 45 minutes or so. And this is something which you can all go and have a look at it. This is in the recent journal of Indian Journal of Pediatrics. Riddhi and myself have published. This talks about the overall approach and how we can simplify evaluation of growth failure. Now, when we talk about short stature, 80% is physiological, CDGP or familial, 20% is pathological. So the first question is it really short stature? The second is it physiological or pathological? Then the question is it primary or secondary? Whether it's nutritional or endocrine. If you answer these 4 questions by the end of this session, our job is done. That's what we're going to do over the next 40 minutes or so. Now, the first question, of course, is whom should we evaluate? And this is from our paper, which is going to come up very recently in Journal of Pediatric Endocrinology on 900 children. What we found that as the height standard deviation score goes down, the chances of pathology increases. So above -2 SDS, only 1 in 40 will have a pathology. If you go between -2 to -3, it becomes 1 in 2. And when you talk about less than -3, it means 80% becomes a pathological cause. So what it means, the worse the growth failure, the more likelihood of pathology. So that's why we've got this traffic light approach. If you have a height more than -2 SDS, wait and watch. -2 to -3, maybe you have to evaluate after some time. Less than -3 is an emergency. You have to stop and take in terms of that. So when you talk about growth failure, children who are really short would require evaluation at all point of time. Children who are short and not growing, height below -2 to -3 SDS, not growing over the next 6 months or a year, will require evaluation. And of course, if you have a child in the normal range also, but who is faltering, you also require immediate evaluation. So short and not growing at all will require evaluation from that regards. And 3 things we'll focus upon are the growth chart, puberty, which of course we'll discuss on the pubertal aspect, and the bone age. So I'll hand over the proceedings to Dr. Sayan, who will start off with the session with the first case. Yeah. And this is more like a sort of a ward round going on, or a clinic going on, in which Dr. Sayan is presenting the cases to our faculty.
So a 12-year-old girl presented to us with concerns of short stature. Her height was 132 centimeters. She has a weight of 28 kg. Her father was 164 centimeters, while her mother was 151 centimeters. So Mahesh sir, kindly tell us whether this child is actually short.
Okay, thank you, Sayan and Dr. Anurag, for giving this opportunity. Before going further on this particular case, I think we should be aware about the growth charts, which growth chart should be used, and what we are going to get from these growth charts. So when we plot this particular height of this girl on a growth chart, we are going to get the absolute status in the form of centiles, and at the same time in the form of height SDS. So that will give the comparison with the population. We should also get the findings that what is the parental expectation from these growth charts. So we should take out the target height, and the target height is usually taken up by calculating by adding mother's height and the father's height divided by 2, and then we should get the target height standard deviation score. Nowadays we can use the corrected standard deviation score, that is height SDS minus target height SDS will give you the parental expectation related to the height. And the third important thing that we can get from the growth charts is the effect of nutrition. So if there isn't weight is more affected or height is more affected, that will give us an idea that if the weight is more affected, we also get the idea related to this particular nutritional status from the BMI SDS. On this basis, we will get if height is more affected, then probably we are dealing with the endocrinological cause. If we are dealing with the weight is more affected, then we are dealing with the nutritional cause. So when we see this particular chart, so the first thing is we should use the IAP growth charts up to the age of 18 years published in 2015. So when we plot the growth chart, we've seen that when we take out the target height by adding this mother's height and the father's height, so this will come round about 154 centimeters. Yeah, it's 151 centimeters. So there will be a target height. So we will plot this target height on the 18 years of age at the growth chart. and then we will take out the plus 6 centimeters and minus 6 centimeters, by which we can take out the target height range. When we draw this particular graph, revert back, and at the time we seen that this height of this particular girl, as such, this is less than third centile. But when we calculated this particular thing, we seen that this is following the parental norms, parental expectation. The next step is that I already told you to take out the weight for height and height for age. So when we take on the height for age is the height for of that particular age is the 50th centile. So when we take on, so in this particular girl, the height age is 9 years and the weight age of this girl is also 9 years. So it's almost the same. So this we can say that this girl is following a particular path expected to the parental expectation. So this girl is belonging to a familial short stature, and when we take out the corrected height SDS score, if it is more than minus 1.5, that suggests probably this child is belonging to familial structure. The MedEClasses E application is having a growth interpreter. We just put these data on those particular parameter, and we will get idea that where this child is fitting, and that will lead us to the familial short stature. So once we label this child as a familial short stature, we don't need any investigations per se for this particular girl.
Sir, thank you for your explanation. So we can diagnose this child as a case of familial short stature according to this point of time. But sir, how do we know that the child will not falter when he comes back to us after 6 months?
Okay. So that is an important thing. The next thing is, so this is a familial short stature. We just need to give the reassurance. And the most important thing we need to do the serial monitoring or the growth velocity we should see. So we followed up this child for 6 months and height reaches to 135.5 centimeter. So you can say there is a 6 month, the height gain is 3.5 centimeters. In a year, it is 7 centimeter. When we plotted this particular thing in the height velocity chart, you can see this girl's 135.5 centimeter is coming at the exactly, if you see this particular point, this point is showing that this child is exactly 50th centile. So it is not faltering below 25th centile. So most probably this child is doing well as per the expected parental expectation.
Yes, sir.
Yes. So I think that's a very important point which Dr. Mahesh talked about for correcting for the family. That becomes absolutely important. Now, if we look at this graph from here, this perspective, we have developed a growth interpreter with just input of these parameters. You will directly get not only the outputs, but also the interpretation. So whatever Dr. Mahesh said was clearly the familiar short stature, and this is what the outputs will also come from that perspective. Now, just to see what happened to this girl, what happened, Sayan, later on?
So when the child was followed up, her growth velocity was 7 centimeter per year for the next 6 months. And this was when this was plotted on the height velocity growth charts, it was at the 50th percentile. So as Dr. Mahesh just mentioned, this child is doing pretty well, and she's a case of a familial short stature.
So Dr. Mahesh, what will be the key practice points for us from here?
It is very important to take out the target height and the corrected SDS. So correct the height for the parental expectation, and at the same time, there is no workup is required when the child is falling within the target range, and at the same time, so there is no workup if height is within the target range.
And follow-up will be.
And follow-up is very important. Follow-up is very important in the mild growth farewell, and the growth velocity is very crucial in following up this child in the subsequent years to come.
Thank you so much, sir. So now we move on to the next case. This was a case of a 13-year-old boy who again presented to us with concerns of short stature. His height this time was 135 centimeters, weight was 30 kgs. His father had a height of 169 centimeter and his mother had a height of 156 centimeter. So Dr. Anurag, is this actually short stature, and how can we move forward in this case?
Thank you, Dr. Sayan. As Dr. Mahesh has already told, we will plot the parameters on a growth chart, the I-PPEC growth chart. And when we plotted, we found out that the height age of this child comes out to be 9.5 years. And the weight age is also 9.5 years. And the mid-parental height comes out to be 169 centimeter. And one more thing, the bone age is at 11 years. We can clearly see that this child is short for the population also and for as per his family norms also. Dr. Sain, any other investigations were ordered?
Yeah, actually, this child came from, was referred to us, and already a lot of workup has been done. So, Dr. Sain, you can highlight on that.
Sir, as far as the screening investigations was concerned, all the screening investigations were normal, but the child was referred to us with a basal growth hormone of 0.1 picograms per ml. So, is this a case of growth hormone deficiency, sir?
Now, I think we should come back to our growth chart. And I think there are 2 or 3 factors which were missed while on the growth chart. First was the testicular size was 3 centimeter, which means that the child has not yet entered into the puberty. And another thing, the bone age was done, which comes out to be 11 years. And when we consider his height as per his bone age, then it comes out to be within the target height range. And also we can clearly see that the both height and weight age are equally affected. And now coming up to the growth hormone levels, I don't think that it was really needed in this child. And also if it is done, then the stimulation test has to be done, and that to be after proper priming, as this child is a peripubertal, in the peripubertal age. So
that is a very, very important message, Dr. Anurag, because this child actually had got a growth hormone stimulation done, but as you very rightly mentioned, was unprimed. So that's a big, big problem that we are seeing in this case. So on prime, this thing, Dr. Anurag has suggested we should do a prime sample. So what happened, Science?
So on priming, the peak GH was 15.2. So what are your thoughts on this, Dr. Anurag?
So it is to be remembered that for any girl who is above 8 years of age and or a boy who is above 10 years of age, a growth hormone assessment is to be done only after priming, either with a ethinyl estradiol or with a testosterone. So, and when we followed up this child, the growth velocity picked up and it landed up to be within the normal range.
So I think this is one of the most important thing to remember, that if you have a short child just around puberty who is just below the chart, it is unlikely to be GHD, most likely constitutional delay of puberty and growth. The problem is basal growth hormone is useless, and then Dr. Anurag has already said that unless you do a stimulation after priming, you will get a wrong result. So what would be the clinical parameters? Now, this is our study which shows that height standard deviation for bone age is the best marker for constitutional delay of puberty and growth. So if your height is short for the age but normal for the bone age, it's basically, this is what height STS for BA tells you. If your height standard deviation for bone age is more than -2, it is usually constitutional delay of puberty and growth, as was seen in this case that we observed in that perspective. So Dr. Anurag, what are your take-home messages from this case?
Well, the bone age and the puberty assessment is very crucial in all the children with for growth assessment, and we should consider constitutional delay in peripubertal children. And growth hormone workup is rarely needed and is to be done in only in the cases with substantial growth delay, and priming is essential before growth hormone stimulation test.
Thank you.
Thank you so much, sir. Coming on to the third case, this was a 15-year-old girl with a 15-month-old girl with a birth weight of 4,000 grams. So large for the gestational age, but with short parents having a mid-parental height of 150 centimeter. Now, this child was meticulously followed up on a growth chart and was found to have faltering. So the failure to thrive caused the diagnosis of RTA in this case. Now, this is the plot on the growth chart that you see. The child was faltering from the initial phase at birth. The child had normal renal function tests, liver function tests, and normal CBC. Had mild metabolic acidosis, was diagnosed as a case of RTA therefore, and given sodium bicarbonate.
So Dr. Rajiv, do you consider this child to be RTA?
No, we need to, no, this is very important because this child was born 4 kgs and the mid-parental height is 150 centimeters. So we need to plot it on the chart, and then we see where the child initially started with and where the child is faltering and trying to reach the final height or is trying to follow the graph pattern too. So if with the normal renal function, the LFT, CBC, and if we also do a potassium levels, then we'll probably come to a realization. And then if we take a detailed history, did the mother suffer from diabetes when she was pregnant? Well, give us a clue as to was this child in front of a diabetic mother with an environment which was responsible for this kind of a situation where the child grew faster at in the mother's womb, and then is trying to take the genetics part of its story. So ultimately, the growth will falter, and the child will then try and follow a pattern which she was where she was trying to follow as per her growth potential.
So this is clearly a typical cash down growth. Very nicely said by Dr.
Cash down growth.
Yeah. So we know that the size at birth is determined by the environment, while the size at final height is determined by genetics. So this switch happens by 2 years. So in 2 years, you may go up or go down. This is going down, nothing to worry. Do not worry. We'll talk about another case of going up of SG and catching up. So this is a classical common situation. So this is infantodiabetic mother and cash down growth. So the messages we get, Dr. Rajiv, from this case are:
the size of the size at birth is determined by the environment in which the baby is in the mother's womb. Secondly, the adult height is determined by the genetics. So if your genetics is, as far as mid-parental height is concerned, is on the lower side, you'll ultimately follow that pattern, and you need not to get worried. Thirdly, as what Dr. Anurag said, the switch occurs at around by 2 years of age. So we have to follow the pattern even before and after that, so that we know exactly where we are leading to. And no workup as such is needed if the things are as are per the parental height of the particular child.
Thank you.
As far as transition is concerned.
Thank you so much, sir. Coming on to the next case, this was of a 10-year-old girl with a height of 120 centimeters and a weight of 15 kgs only, was diagnosed as a case of growth hormone deficiency. So Dr. Riddhi, do you agree with the diagnosis?
So Riddhi, this is the growth chart.
Thank you, Dr. Sayan. So this growth chart showing that weightage is around 5 years and height age is around 7 years. So this is clear-cut nutritional pattern of short stature. So this screening investigation done in this child, which is normal, TSH is normal, even TTG is also normal, and IGF-1, which is lower for the age, that is 120, and further investigation done, which are basal growth hormone, which is 0.5. So based on this low IGF-1 and low basal growth hormone, child was given diagnosis of growth hormone deficiency. But as beautifully explained by Dr. Anurag in previous slide, that no role of basal growth hormone in diagnosing growth hormone deficiency, which we will discuss in subsequent slides. So bone age is also important screening investigation in this child while approaching every case of
bone age by far is the most important and confusing tool, and we often get results which are very weird from age 5 to 18 years, and we've got fracture and rickets, and those sort of results are there. So how can a pediatrician, Dr. Riddhi, easily assess bone age? And maybe in 2 minutes, how can you explain somebody to get a bone age done? Is it even possible, or have you made it possible? We wanted to know about that on that regards. Yes.
Yeah. So before ordering bone age, always keep some points in mind that always write prescription at X-ray left hand and wrist, including fingers. Otherwise, you will get X-ray like this, and there is no value in assessing bone age of this X-ray. Fingers should be fully spread. It should not be close to each other, and the X-ray should be properly exposed. It should not be overexposed or underexposed. Otherwise, you will not get any morphological criteria of smaller bones. So
the other question, Dr. Riddhi, is that which bones to look at in undergraduate, in post-graduation? Most people say count the carpal bones and subtract by 1, you will get the bone age. Some people say look at radius and ulna. Which bones are really important in terms of bone age assessment?
So smaller bones like carpal bones and appearance of the epiphysis in the smaller phalanges are important in less than 3 years in boys and 2 years in girls. But after the infantile and toddler age, there is no role of the carpal bones in assessing bone age. And the importance of bone age assessment comes only after 3 years of age. So in pre-pubertal and pubertal years, always look for the epiphysis, that is smaller epiphysis in phalanges. Look for the size of epiphysis, shape of the epiphysis. If the size of epiphysis is smaller as compared to metaphysis, the age is around less than 4 years. If it is slightly bigger, then it is around 4 to 6 years, and in 6 to 8 years it becomes equal to metaphysis, and after 8 years it begin to grow wider than the metaphysis. After that the shaping is started, and then fusion becomes in the pubertal years. So always look for the different areas in different ages. We should keep this slide in mind, but it is not easy to apply this in routine pediatric practice, and it is very difficult to remember also.
Yeah, every time I've done a workshop of around an hour or 2 hours also of bone age, everybody says that I don't know, I have to understand now, but when I go back to my clinic, I just forget everything. So what can be done in this setting?
So though routine Tanner Whitehouse 3 and the Grulich pile method is available, but it is very difficult and cumbersome to apply in routine pediatric practice. So we have developed this bone age application for easy bone age estimation in routine pediatric practice. Though this slide looks very complex, but don't worry, the application is very easy. This slide gives idea about the development and validation of the bone age application. So it is developed from 307 radiographs. We have first rated each and every site of the Tanner Whitehouse 3, that is 13 different sites by 3 expert users, and then these were compared with a standard method of Tanner Whitehouse 3 in another 90 radiograph, and best region of interest were selected based on regression analysis. After that, they were loaded on mobile application and validated against the gold standard method in another 200 radiograph by 2 expert user using the various statistical parameter. And it is also compared with the bone expert and Tanner Whitehouse 3 by both expert and non-expert user, which are not using bone age estimation in routine pediatric practice. And we found that this method is as precise and as accurate as Tanner Whitehouse 3 method, and is also comparable with bone expert. So we can easily apply this method with lesser time of assessment in pediatric practice. So can we have next slide?
How does it work, Dr. Riddhi? Yeah.
So we have to just focus on only 5 sites, that is middle phalangeal and proximal phalangeal epiphysis of middle finger, proximal phalangeal epiphysis of thumb, radial and ulnar epiphysis. We have to enter only 2 input parameters, that is gender and date of birth, and then select the image which is closest to the patient's radiograph, and only look for the parameters like size of epiphysis, shape, appearance of white line, and how the capping started, what is the fusion. And when we press select every 5 images and then press calculate button, we will get the bone age, also the range of the bone age. So this method is as precise as Tanner Whitehouse 3, and this is easy to apply in routine pediatric practice. So please try to apply this method.
So Dr. MedEClasses really made looking bone age as easy as making Maggi noodles. Within 2 minutes, you can do that. The study has been done, and she has actually won 2 awards for this novel application, which is there. It's under publication currently. So I think big round of applause for Dr. Riddhi and Dr. Cheta and Dr. Sajdi, who are part of this team to really develop such a wonderful tool for the pediatrician. Within 2 minutes, you can get the answer from that. Now let's go back to the case, Dr. Riddhi. Why do you think this child having a nutritional cause was diagnosed as growth hormone deficiency? What are the problems in growth hormone assessment?
First of all, the IGF-1 was done in this child, which is the screening investigation for growth hormone deficiency. But there are some caveats doing the IGF-1. IGF-1 is an age-dependent parameter, which is clearly shown in this graph that below 5 years, there is no role of doing IGF-1, which has no value in differentiating the growth hormone deficient patient and normal patient. Secondly, IGF-1 is also dependent on nutritional part. So this child was malnourished. Weightage of the child was very low as compared to height age. So IGF-1 was waste of money investigation in this child. Secondly, growth hormone, basal growth hormone was done in this child, which was totally waste of money, because growth hormone has got Growth hormone is pulsatile hormone. Is that got diurnal variation also, and its level is also affected by the meal. There is no role of doing basal growth hormone in diagnosing growth hormone deficiency. Always do growth hormone stimulation test, and that should also be done under priming in peripubertal years. Otherwise, you will get false diagnosis of growth hormone deficiency. So coming back to the case.
Yeah, thank you so much for the explanation, Dr. Riddhi. Now, the workup showed that the IgA was undetectable in this case.
Okay, so this suggests the diagnosis of celiac disease, even though TTG was normal, and the diagnosis was confirmed by duodenal biopsy, suggesting the complete villus atrophy. So always think of nutritional and treatable causes of short stature before jumping to the endocrine causes of short stature. And when we started gluten-free diet in this child, there was dramatic improvement in oxological parameter of height and weight. So learning point.
Yeah, kindly give us
from this case are. So learning points from this case are that always consider nutritional cause of short stature when weightage is affected more as compared to height age. Consider IgA in each and every suspected cases of celiac disease, because some of the cases of celiac disease have IgA deficiency, and we can falsely not diagnose this celiac because by doing TTG, that is screening investigation for celiac disease. IGF-1 has no role in malnourished children and children less than 5 years of age, and
there's no role of basal GH, of course.
No role of basal growth hormone in diagnosing growth hormone deficiency.
So I think the big message which came out of from these cases that the most important thing to look at in a short child is the weight, not the height. If you have a short and thin child, it is nutritional. If you have a short and plump, it's endocrine. I think that will carry forward in the next case as well, Dr. Sayan.
Yeah, just the opposite case to the child that we just saw. This was an 8-year-old boy with a height of 100 centimeters only, had a weight of 18 kgs, was diagnosed as a case of celiac disease. Dr. Mahesh, sir, do you agree with the diagnosis?
Thank you, Dr. Sayan. Can you just show me the growth chart before accepting that this is a short stature child? Okay. So if you can see in this particular growth chart, this child's height is definitely falling less than 3rd centile. So that child definitely requires evaluation as per the parental expectation, if you can see. And when we plotted the height age and the weight age, and I think if you see this particular chart, growth chart, then you can see the height age of this child is 4 years and the weight age of this child is 6 years. So definitely his height age is more affected than the weight age. Can you show me the other investigations also on which basis?
Yes, so the diagnosis was primarily made because of a TTG which was 32, and the child was referred to us with the diagnosis of celiac disease.
There was no biopsy done. Most importantly, no biopsy was done.
Okay. Yeah. So that was my next question. That if the TTG is 32, that is definitely on a higher side, and just like Riddhi says, there is no role of basal hormone. So doing growth hormone as a single value probably not meaning much. So this TTG was definitely on a higher side, but definitely this is not the gold standard to make the diagnosis of celiac disease. So is the duodenal biopsy done in this particular child?
The duodenal biopsy was not done on referral.
Okay.
But the child was referred mainly because there was no effect on the height of a gluten-free diet.
Okay. So that is also one of the indicators that probably this child is not actually in the, so there are few indicators till now what we are getting, that this child's height age is more affected than the bone age. That is against the nutritional cause, and nutritional causes like celiac disease, usually the weight per age is more affected than the height age. And this is the reason, and you can see in this particular slide, in nutritional cases, the weight per age is more affected than the height per age. And in contrast perspective, in endocrine causes, there will be more height for age is more affected than weight for age. So this is happening in the similar in the child. So this child definitely need a confirmation by doing a duodenal biopsy. But till now, this looks like to be an hormonal cause or endocrine cause. So when you plan a workup, so duodenal biopsy, this child is normal.
So we did a duodenal biopsy in this case, and it turned out to be normal, sir.
Okay, so definitely the duodenal biopsy is normal, and we had a basal growth hormone level available with a low volume. So probably this child is an endocrine cause and a level is available, but we should not confirm the diagnosis of growth hormone deficiency until unless we will do the growth hormone stimulation test. So
yes,
when
sir,
we perform the growth hormone,
after a normal biopsy, so we did go ahead with a growth hormone stimulation test, and a peak growth hormone levels of 1 was found in this case, sir.
So this is definitely very low. So this is definitely very low on the peak side. So this is suggesting that this child is having a not a celiac disease. This child is having a growth hormone deficiency, that is an endocrine disorder. And any child whom you diagnose a growth hormone deficiency, the MRI head is most important investigation to find out any pituitary, hypoplastic pituitary. So that is an important thing that you need to be aware in that particular child.
The MRI showed a hypoplastic pituitary, sir. So what to make out of this MRI, sir?
So this child is definitely having a growth hormone deficiency in this particular child, and that is confirmed by doing the growth hormone stimulation test.
So just Dr. Mahesh, how do you approach a child like this case had a TTG level which was within 10 times the normal range? So what do you think should have been done? If you go by this SPEGN criteria, what do you suggest what should have been done in this case?
Okay, so in this case, I think there are multiple criteria that say probably this is an endocrine cause. One thing is the height for age and the weight for age. Second thing is that duodenal biopsy is normal in this particular child. So we get in our practice a lot of times there may be, and when we do the IGA, this may be negative. There may be a 1 to 10 times of the upper limit. So the biopsy is indicated in those children. If the above 10 times upper limit, then EMA antibody can also be done. And on the basis of this, because the child is having almost 30, so this is definitely more than 2 to 3 times of the expected normal. So you do the duodenal endoscopy and biopsy. If the Marsh criteria, if there is a 0 or 1 on the histology, then celiac is excluded in this particular child. If there is a criteria of grade 3 and grade 2 and grade 3 onward above, then it is a suspecting of celiac disease. And if the TTG IgA is more than 10 times and EMA antibody is also positive, you can confirm that this is a celiac disease. If this is a negative, then you can go for the biopsy.
I think the most important message which comes from this case is the pre-test probability. Now, if you look at a child who is short and plump, having a celiac disease pre-test probability is very low. In that setting, just because the TTG is widely elevated doesn't make any sense. You have to go for biopsy. If, on the other hand, you had a child like the case which Riddhi discussed and TTG was more than 200, maybe you could have missed the biopsy, but there's no point not doing biopsy in this case. So again, this is what we try to do to differentiate nutritional from endocrine cause. And what we found was that BMI SGS was the best marker to differentiate nutritional from endocrine. But the key message even there is that you will miss celiac disease if you do only in everybody who is lean. So TTG should be done right across the spectrum, but you have to interpret TTG properly. That's very important. And if it's less than 10 times, do a biopsy. That's a big message in that regard. So I think the practice points, Dr. Mahesh, from this ones are?
Yes. So I think you very rightly said that always think an endocrine cause when you're seeing a child who is short and plump. And the second is biopsy is always mandatory to diagnose the celiac disease. And MRI is an essential investigation in children where you diagnose a child as a growth hormone deficiency.
Thank you. Next case.
Thank you so much, sir. So this was a 6-year-old boy with a height of 90 centimeters. So very short, had a weight of 12 kgs, was diagnosed as a case of nutritional rickets, received multiple doses of vitamin D, but still the X-ray was suggestive of rickets. His calcium was 9.2. His ALP was also normal, but a potassium which was done revealed the potassium level of 3.2. So what do you think, Dr. Anurag, of this case?
So we can clearly see it is a case of rickets with growth failure, and cause could be nutritional or malabsorption or renal failure or RDA. So we will first proceed with the therapeutic trial of vitamin D and the calcium in all these children. And as in this child, we have already given the vitamin D and calcium in proper doses, still it is not responding. Then we will look for the phosphorus levels and also the potassium level. And the potassium level in this case is on the lower side.
Potassium was
3.2.
Yes,
yeah,
sir, normal.
And the phosphorus is within normal.
Yes, sir.
So we will order a blood gases in this child.
Yes, sir, blood gas was done and it showed a pH of 7.1 with a base excess of -15 in this case.
So this is a clear case of renal tubular acidosis.
So the urine pH was also 6.8 in this case.
Yeah. We will look for the urinary pH to differentiate whether it is proximal or the distal RTA.
Yes,
We
and there
can
was
clearly
also
see that there
calcification.
is. Yeah.
Yes, sir.
We can clearly see that there is a metabolic acidosis along with the alkaline urine. So
Yes.
it is a case of distal RTA.
Thank you so
And
much.
we have to do a ultrasonography which shows this
Yes, sir.
calcifications.
So what are the take-home messages, sir, in this case?
So we should think of renal tubular acidosis in all children with rickets and along with the growth failure, and low potassium is an important clue in this case, and blood gas and urinary pH is diagnostic for RTA.
Thank you so much, sir. Coming on to the next case, this was a 14-year-old girl with a height of 120 centimeters. She had a weight of 32 kgs, and this is how she looked on examination. She had normal screening tests. Now, Dr. Rajiv, how do we move forward in this case, sir?
You have to see this girl who is 14 years, short stature. You see the slight webbing of neck, which you can appreciate from the picture you have provided. In fact, I saw a case back only, and she has got wide nipples placed widely.
Yes,
so with normal CBC, LFT, RFT, and thyroid function and PTG, so we'll have to go into and see what things work. We have. Can you show me some more features so that we can explain and maybe have some idea to what the clinic does? Like if you see,
Hello, sir.
I think there's some problem there. So this is a girl whom we can see very clearly classical features.
Hello.
Yeah, Dr. Rajiv. Yeah. Dr. Rajiv.
Yeah. So you can see the short fourth metacarpal bone in this child.
Yes, sir.
And hello. Can you hear me?
Yes, sir. Yes,
please
sir.
go ahead. Yeah.
Am I audible?
Yes, sir.
Yes,
You are
sir,
audible.
please.
Yeah, and the other features, then the FSH may be high because initially in these children, this child has got, to my mind, Turner syndrome. They can be high FSH to begin with, and then once we follow up, and then we'll be able to see that this child has the cystic, may have features like cystic hygroma, may have kidney issues, and all kinds of features which will suggest that this child has got the cardiac abnormalities may be there associated with it. So we have to do a karyotype on this child for clear picture, because then only we'll be able to confirm the diagnosis.
Dr. Rajiv, one question which is often asked by me, for me, is that this girl looks like Turner's. Everybody knows if walking, maybe you can have she might be the second object visible from the space. Like they say China, Great Wall of China is visible. If you have a girl walking like this looks like Turner syndrome. FSH is 72. Why are you wasting money in doing a karyotype? That is what the pediatricians ask me. So how do you define doing a karyotype in this girl? Like this is very classical Turner's.
Because they ultimately land up, they have got congenital dysgenesis also. The ultimately what happens is over a period of time there'll be ovarian failure in these children, and this could be an indicator. So unless you do a karyotype, you will not probably be able to finally make a final diagnosis.
Very important message with Dr. Rajiv is saying that even if you know that this girl is Turner's, you have to do a karyotype because you know of gonadogenicis, Y cell line, risk of carcinoma. Those points become very, very important. So you have to do karyotype in everybody in that regard. So what are the key points, Dr. Rajiv, from there?
So we have to consider in all children, on all girls, even if they don't have full features, to consider Turner syndrome, especially in girls who are short stature. So karyotype is mandatory in all these patients. And we should also screen for other associations in these patients. They can also have diabetes, and they can have celiacs may be associated with them. And there is no need for growth hormone stimulation unless we plan treatment, because all those parents who are willing for treatment, then we go for growth hormone stimulation, find out exact levels, and then we give them, because we need not to miss that window time where the growth hormone can be beneficial to these patients.
I think two big messages which Dr. Rajiv is giving out here is that one, karyotype is absolutely mandatory. And growth hormone levels, we may do stimulation, but even if they are normal, we may still consider treatment. These are the two big messages coming out from this case. Yeah, Dr. Sain, carry on.
Thank you so much, sir, for taking us through this case. Now, coming on to the next case, this was a 5-year-old boy with a birth weight of only 2.1 kilograms. He complained of, his parents complained of him having poor growth, but had normal development. So at 5 years of age, this child presented to us with a height of only 90 centimeters and a weight of only 10 kilograms.
So Dr. Riddhi, what do you think of this child who is having such a short height that we are seeing? And one key thing that you have looked on is the birth weight.
So this boy born with the low birth weight of 2.1 kg, and his mother was complaining that child is always on the lower side of growth, and child has normal development, no dysmorphism, and we have ruled out the screening the nutritional and treatable causes of this short stature. So this child required growth hormone therapy without doing growth hormone stimulation test, because this child will never grow again. This will remain always on the lower side, because if so, growth in the SG is like double-edged sword.
Yeah, so just before that, what we heard is that a lot of children with SGA have metabolic syndrome and they develop problems. So why are you giving growth hormone which can cause worsening of metabolic syndrome?
So growth in the SG is like double-edged sword. If they are slow growers, they will grow slowly, they will hit the puberty early, and they land up with a short adult, but they are healthy. They will not develop metabolic complication. But in another group of individuals which show rapid catch-up growth, they tend to gain more weight during pubertal years, become overweight and obese, and then they become tall adult, but they develop metabolic complication like type 2 diabetes and dyslipidemia. So they need the early screening for metabolic parameters. So this graph clearly showed that whatever catch-up growth occurs by 2 to 4 years of age, after that the growth will, the child will not grow further. So if the child is not growing by 4 years of age, we should start growth hormone therapy without doing growth hormone stimulation test, because they have intrinsic growth hormone resistance phenomenon. So they will need growth hormone for the.
I think the big message which came from this case and Dr. Riddhi was that this child is short. He will enter puberty early. If you don't intervene, he's going to land up short. That's very, very clear. Very important. If your child is not catching by 2 to 4 years, think of GH. So I think that's what the key practice points, Dr. Riddhi, from there.
So monitor growth in child with SGA always, because if they are slow growers, they need growth hormone therapy. If they are rapid growers, they need early screening for metabolic parameters. If there is no catch-up growth by 2 to 4 years of age, start growth hormone therapy. Assess the treatable causes of the short stature and rule out that. After that, start growth hormone therapy. And there is no need for growth hormone stimulation test in this case for starting growth hormone therapy.
So I think we're not discussing too much about diagnostics here, but regarding growth hormone, many points have come in. 1, don't do a basal growth hormone. 2, do a primed growth hormone in a peripubertal child who is short. And 3, do not waste your money in doing a growth hormone stimulation in Turner's or SGA, in which there are other indications of growth hormone therapy.
So coming on to the next case, this was a 10-year-old girl with a height of 112 centimeters, weight of 24 kg. Now his mother complained that the child is not growing at all. He had a normal screening investigations. So Dr. Mahesh, are we missing something in this case?
Thank you, Dr. Sayan. I think if you see this particular child, this pictorial photograph, then this child is definitely short, looks like by the age of 10 years. If you see that there is definitely an upper limbs and lower limbs are looking little shorter, and apparently there is an upper segment and lower segment disproportionation is there. So the anthropometry is definitely going to play a very important part in this particular child. So when you do probably the upper segment and lower segment ratio, it is 1.5:1. So at the age of 10 years, what we expect that upper segment, lower segment ratio should be 1:1. So in this side, definitely there is an upper segment, lower segment is not suggestive of that normal growth. So this is probably a case of skeletal dysplasia, hypochondrodysplasia. In case if you really want to work up further, we can go for the mutation studies. This is the FGFR receptor mutation study that can be planned in this particular child. Sometimes these children can present just like a rickets. So that also needs to be ruled it out.
Very important. Rickets and large head. Often they will diagnose as hydrocephalus. I have seen children presenting at 1 year of age, people say hydrocephalus, but they are actually achondroplasia. That's a big message there. So the practice points clearly that body proportions, Dr. Mahesh, are very important.
Yeah, so that is very important. Then every child, whenever you thinking about a short stature, the body proportion measurement is very important. Hypochondroplasia sometimes resemble rickets, so you need to be very careful when you are thinking about that. There is no need for extensive testing just for the growth hormone, finding out the growth hormone deficiency. Genetic test is definitely important for the prenatal diagnosis in this particular child.
Thank you so much, sir, for again re-emphasizing for us students the importance of proper anthropometry. So coming on to the next case, this was a 7-year-old boy with growth failure. He had a height of 102 centimeters and a weight of 16 kgs. Now was referred to us with doll-like faces and a low growth hormone level and a low IGF-1 level. Now, when this child came to us, he had a firm hepatomegaly of 10 centimeters with a high SGPT. So Dr. Anurag, is this a case of growth hormone deficiency?
Yeah, now this child is, although there is substantial growth failure and doll-like faces, along with a low growth hormone level and low IGF level. But what was missed on systemic examination was a huge hepatomegaly, and it has a raised SGPT level. So we all know that impaired liver function test results in low IGF-1 levels also. And this is most likely a case of glycogen storage disorder. And generally, the blood sugars are on lower side, and on induced fasting, it resulted in ketotic hypoglycemia. And when we follow the flow chart for ketotic hypoglycemia, the lactate levels were done. The lactate levels out to be normal. Normal lactate with the organomegaly, it most probably diagnoses GST type 3, 6, or 9.
I think very important message there, that always think of systemic causes. Do not rush for an immediate workup. And if we had done a liver, checked for the liver, we would not have done all those investigations very clearly. So Dr. What are the key points, Dr. Anurag?
Don't rush for growth hormone workup in all cases of growth failure and doll-like faces. Systemic examination is very crucial, and organomegaly suggests GSD. And although a systemic examination is to be, and a thorough systemic examination is to be done before the endocrinal workup.
Thank you so much, sir.
So just to summarize the approach that we'll be discussing about, this has been published just in Indian Journal of Pediatrics. We have tried to develop a very simplified pathway for evaluation of growth failure, which looks mainly on clinical parameters and then uses investigations much less. And if we just look at our application, it uses these parameters. So we start off with how short the child is. Is the child short for the family or not? Is the child short for the bone age? So if the child is not short, no evaluation. Child is not short for family, no evaluation, familiar short stature. Child is not short for bone age, it is constitutional delay of puberty, and only then you start workup, and that becomes important right from clinical examination, clinical clues, and then you do the basic screening workup, and then based upon that, you work up whether you need a TTG and an IGA. We recommend TTG for everybody, IGA and fecal calprotectin for children who are having nutritional pattern of growth failure, and GH at the end. And we are doing a lot of cost-effective studies, and we find that we can save a huge amount of money if we use this pathway. And this is what is going to come up very soon in JPEM as well, the publication that we were discussing about in that regards. And this is the validation of this app, which Riddhi had done, which showed that there was a concordance in over 90% cases in this setting. So this is something which you can use very simply using a growth interpreter. It will tell you the interpretation, and you'll get the right diagnosis right away from that perspective. Now, moving on to the next spectrum, which is now becoming more common. Sayan?
Yes, sir. This was a 12-year-old boy who came to us with obesity. He had a height of 160 centimeters and a weight of 70 kg. Now, screening investigations revealed a TSH of 7.91, and the child was advised thyroxine. So, Dr. Rajiv, is the high TSH causing this obesity?
No, this is the other way around. In fact, what happens is in obesity, there is a stimulation of hypothalamic pituitary axis, and the TSH gets raised, but the thyroid gland itself is normal. So there are multiple factors which are responsible, and leptin also one of the factors which is responsible for the TSH rise. So this could be normal, and as the child starts loses some weight, probably the thyroid functions will show as normal. So it will not be prudent to start thyroxine in this particular child.
Very, very important message. It is the effect of obesity and not the cause of obesity, as Sayan put it.
Thank you so much, sir. Coming on to the next case. This was a 12-year-old girl with a height of 130 centimeters. She had a weight of 58 kilograms, normal screening tests, and was reassured. After a while, the child started to have rapid weight gain. So, Dr. Riddhi, what was missed in this case?
So, can we have growth chart of this girl?
Yes.
So, yes, so this is the typical growth chart where height age is affected, height age is less than weight age. And so this is typical growth chart of endocrine cause of short stature, needs the endocrine workup and detailed history examination, pubertal assessment for the endocrine cause of short stature. So thyroid function test was normal in this girl, but when we examine this girl, there is typical Cushingoid feature of moon-like fish, buffalo hump, hirsutism, and even purple stria. And overnight dexamethasone suppression test showed the cortisol of 154, which is very high, suggesting endogenous hypercortisolism. So this girl was missed in initial stage because the girl was not plotted on growth chart and she was not examined properly.
So the most important thing to look at in a short child is the weight. The most important thing to look at in an obese child is the height. If you have short and obese, it becomes endocrine, and if you are tall and obese, it becomes constitutional. But what are the exact cutoffs that we should look at? This is our study which Dr. Manoj has been doing in our center. 458 children with obesity. What we found that although this is true, that children who have a pathological cause are short, there is no cutoff. So you can't say, especially for hypothyroidism, you have to do a TSH and FT4 in everybody. That's a message which is coming out of it. So we cannot prove a cutoff which is available in that regards. We have recently also coming up with an obesity interpreter, which Dr. Naveen has been working on. And this obesity interpreter looks at very, very basic things: the current height, the weight, development, facies, as well as puberty. And based upon these 5 things, we give a diagnosis, whether it is pathological, whether it is genetic, vision abnormality, we go for some specific syndromes. So this is going to really help out. On the drop of a button, you will get immediate interpretation from that perspective. So I think that's pretty much the main point, that obesity is usually constitutional. Height is most important. No need to treat mild elevation up to 10, which we'll discuss much more in thyroid section, and short and plump is endocrine. So I think thanks all of you. Thanks Dr. Sayan, thanks Dr. Mahesh, Dr. Rajiv, Dr. Riddhi, and as well as Dr. Anurag Katiyar for this wonderful session. And we'll take a few questions which are there. We'll try to take few of them very quickly and in that regard. So there is a question from Dr. Phoebe. TH is not factoring in 13 centimeter subtraction or addition. So that's a very, very important factor. The novel knowledge, of course, we talk about that when you are looking at child's height, you take mother's and father's height, divide by 2, you add 6.5 centimeters for boy and subtract 6.5 for girls, and then you use a range in that perspective. The studies have shown that the range is actually 1.5 standard deviation score. So when we say that your height is within the target height range, it means that you are within the 1.5 standard deviation in that perspective. The next question is from Dr. Seema Rai. Can IGF-BP3 give us a concrete evidence of GHD and we can skip GH stimulation test? No, both IGF-1 and IGF-BP3 are actually screening tests, and we should not rely on that. We have to do a growth hormone stimulation test. And I would say, given the lack of reliable local reference values available from India and many of the other resource-poor countries, it will not a very helpful test from that perspective in that regards. Now, there was a question from Dr. Edele, what is the cost of GH in India? Now, if we talk about GH in India, 1 unit approximately costs around 300 for the international preparation, 300 rupees. And for the Indian preparation, they cost around 150 to 200. So on an average, if you have a 10 kg child who is on 1 unit per day, we're talking about 9,000 rupees a month for the international brands and maybe around 5,000 for an Indian brand. That's what we're talking about. Dr. Naresh is asking about if bone age required to differentiate from SGA and endocrine related cause. So bone age is of course an important part of evaluation. So if you have a SGA child, you will do a bone age because it may be advanced. But if you're SGA and not growing, that itself gives you an idea. And bone age is not a discriminatory test. It will tell you whether it is delayed or advanced. It can't differentiate. So the role mainly is height prediction. How much time can you wait? We'll go from that perspective. Dr. Seema is asking if GS resistance is present, so we need higher dose in SGA. Yes, we are not talking about growth hormone therapy. We have got a big module which is available on the web on the IGF deficiency, which talks a lot about growth hormone therapy as well. The key message is that the growth is a bit higher, maybe around 33 microgram per kg in that perspective, which is around 20% more as compared to GHD. Dr. Edele is asking, in case of obesity, what is the cutoff level for hypothyroidism? So if your TSH is more than 10 or between 6 and 10, and if you have goiter or thyromegaly or TPO positivity, you will consider treatment. Otherwise, treatment is not required from that perspective. So